Hi, welcome back. I hope you had something to eat. I hope you let your hair down. Did you go to the exhibit hall? Did you guys were you able to network? If you weren't able to network, we're not able to go to the exhibit hall. You will be able to later in the day, and even a little bit, I think, after. But for right now, we are moving right along. And I am really proud, actually, to be introducing MyHIN's Chief Policy and Privacy Officer, Shreya Patel, who will be heading a panel Beyond Right of Access. Shreya? Hi.
Hi there.
I'm so excited. Every time you lead a panel, I learn something new. So take it away.
Awesome. Well, I'm really looking forward to this next one as well. Good afternoon, everyone. This is Shreya Patel. As Joanne mentioned, I am the Chief Policy and Privacy Officer at MyHIN, and it is my pleasure to introduce the next session that we're going to be having today for Connecting Michigan for Health and More series. So over the next 45 minutes, we're going to discuss right of access and beyond. And just as a refresher, right of access includes an individual's ability to request and receive their own health record in a manner that is not burdensome nor costly. So we've seen rules go into effect from CMS that mandates how right of access should be accommodated over the last year through things like the patient access rule. But this session is really going to go beyond that and ask questions that are more forward thinking, such as what is required of individuals or orgs that are not included in that patient access final rule in that small set of payers. What do patients need from the health IT space in order to feel empowered to request and use their records to make informed decisions? What challenges still lie ahead in this space, and more. So we're going to hear from two great experts on this topic, and it is my pleasure to introduce you to our very first speaker, Devin McGraw. If we could just pull up the slide deck. Oh, perfect. So Devin McGraw is lead on data stewardship and data sharing for the Citizen platform at Invitae. Previously, she directed U.S. Health Privacy and Security as Deputy Director for Health Information Privacy at the Office for Civil Rights as a part of HHS, and she also served as Chief Privacy Officer for the Office of the National Coordinator for Health IT, or the ONC. She is widely recognized for her expertise in health privacy, and she directed the Health Privacy Project at the Center for Democracy and Technology for 6 years and led the privacy and security policy work for the High Tech Health IT Policy Committee. She has also served as Chief Operating Officer for the National Partnership for Women and Families. And Devin, in addition, has advised many health industry clients on HIPAA compliance and data governance while a partner at Manott, Phelps & Phillips LLP. She's graduated from Georgetown University Law Center, and she has a master's of public health from Johns Hopkins University. So please join me in welcoming Devin. We really look forward to hearing your insight on this topic.
Great. Thank you so much, Shreya. I really appreciate it. If we can pull up the first slide in the deck. First of all, I just really want to applaud you all for including a panel on patient access to data. Obviously, we think it's a pretty important focus, and completely agree that while the rule that CMS put forth that allows patients to more easily get their data from health plans regulated by CMS is an important development, there's so much more to speak about in terms of the right of patients to get their data and how do you do that in a way that gives them something that they can really use. So I am with a platform called Citizen. We are now part of the genetic testing company Invitae. It's a patient-mediated platform that allows patients to collect and store their medical records from wherever they've been seen. But we don't just give patients a shoebox of documents. We actually turn that data into computable, diligent, and relevant data so that it's useful for them. They can use it to get second opinions. They can use it to see if they are eligible for a clinical trial. They can use it if they want to contribute to research. We have focused in particular on cancer and rare neurological diseases. And as we first launched the platform, this was in part due to our founder having lost his youngest sister to metastatic breast cancer when she was just in her 40s. And he really experienced the frustrations at really getting access to all of his sister's health information in order and in a way that made it usable for her in terms of getting additional opinions from oncologists, but also being able to see if there were clinical trial matches, as well as essentially paying her data forward. We also at Citizen provide some data management and analytics software to health information exchanges. And this may at first blush seem like two very distinct sets of activities, but I promise you that I will loop them together during this presentation because they are related. Next slide, please. Just a little bit more on how we do what we do in the Citizen platform. Essentially, patients come to us voluntarily and ask us to collect their data from all the places they've been seen. We actually leverage the good old HIPAA right of access, been around for a couple of decades, long before some of these other newer initiatives around patient access. But what's novel about the HIPAA right is that it's the right to all information and not just necessarily what's available in a portal or through an API. It includes images, the actual images, not just the imaging reports, genomic testing, pathology reports, et cetera. Sometimes information that's not necessarily resident in an EHR. Because it is collected for the patient and then the patient then decides how to share it, it's essentially a 360-degree view. It can include also patient-reported outcomes, and it can follow the patient throughout their entire lifetime. I mean, of course, depending on how soon they join Citizen and how much data we're able to get for them in terms of how far back. And then ultimately, we put opportunities in front of patients for them to share their data. They can share it with a family caregiver. They can share it with another doctor. But it is really always up to the patient in terms of whether they share it or not, whether that data is identifiable or de-identified. Next slide, please. So this is a build. So you can just go ahead and load up a couple of other of the slides, please. There you go. This essentially is part of what we do with our users' documents once we get them. I mean, you know, we're obviously collecting a lot of information. Sometimes it's pages and pages and pages of documents. Someone needs to get a second opinion. That's hard for the next doctor to have to go through. So we extract the relevant data elements in a way that they can read so that they can get a sense of sort of where they are in their particular journey, whether it's a health journey or one involving a complex condition. Next slide, please. But it's not just readable. It's computable so that it can actually then be utilized in terms of sort of fitting into algorithms like clinical trial matching algorithms, et cetera. So both of those aspects are part of what a user gets on the Citizen platform. Next slide, please. Yeah, we probably had one more build there. Next slide. I think the next one. Okay. So I want to talk a little bit about information blocking because this is one of those new sets of regulations involving access to data, in this case, access to electronic health information that does have an impact on the ability of patients to get their health information. It is in addition to the HIPAA right of access, although it doesn't cover all of the same entities that the HIPAA right of access applies to. For example, the HIPAA right of access applies to health plans. Even those that are not regulated by CMS's new rules on access still have to provide data to patients when they request it. The information blocking rules don't necessarily apply to health plans as health plans, but they do apply to health information exchanges or health information networks and any entity that might meet that definition. So if a health plan has a kind of unique set of functions where they're actually facilitating the exchange of electronic health information between two other entities, they might actually fit that definition. It really depends on the activities of that plan. But this rule also covers healthcare providers and it covers developers of certified health information technology. And essentially, I mean, this is actually the official slide from the Office of the National Coordinator for Health IT regarding what information blocking is. This is a good resource for you to use in terms of if you need the exact definition. It's a legal definition, so it's a little wordy, but essentially it means that you're blocking information if you're engaging in a practice, which can be an actual action or an omission that makes it hard to access, exchange, or use electronic health information. And so this can range from, denying somebody who requests information to just making it more difficult by charging a lot of money or taking a lot of time, etc. Now, there are some exceptions to information blocking. Essentially, when Congress developed the definition of information blocking in the Cures Act, they asked the regulators to come up with some acts or practices that, of course, might pose obstacles to health information sharing, but they were good obstacles like privacy and security. And so they have identified these exceptions. Next slide, please. Before we get to the exceptions, I'm getting a little bit ahead of myself. It's important to understand that if you are covered by these information blocking rules, then those rules apply to any request for electronic health information for any purpose. As we'll see in a minute, there's an emphasis in these rules on sharing data with patients, but that's not all that these rules apply to. And then, of course, intent does matter. You can't accidentally information block. You have to either know or should know that the actions that you're taking are going to make it more difficult for people to access health information for a legitimate purpose. Or if you're talking about a healthcare provider, you actually have to know that the practice is likely to interfere with information blocking. So that's important. That's important to put all those elements out there. Next slide. Now we'll get to the exceptions. So there are 5 exceptions for not fulfilling a request for information. And we don't have time to go into detail on some of these exceptions. They do have a fair amount of detail. It's not like you can come up with sort of any excuse and call it privacy or call it protecting somebody from potential harm. There are some details to these exceptions that are important to understand. Next slide, please. There are also some additional exceptions that go to the content, the way that requests for information are granted in terms of what's the mechanism for getting information, what's the particular form or format or content, and how do you kind of negotiate that to make sure the requester is getting the information that they should be getting because they are legally permitted or required to be able to obtain it, and matching with the technical capabilities of what the particular entity covered by these rules could actually accomplish. There's a fee exception. It doesn't apply when you're talking about getting data for a patient and you're talking about facilitating electronic access where there's no manual effort involved, that you can't charge a patient fees under the information blocking rule. This is quite distinct from HIPAA that does allow fees to be charged, but they have to be fairly minimal. But it does have to be for electronic, that kind of seamless plug-in type of access that is envisioned by that particular exception. And then there are abilities to charge fees, but obviously you need to look into that exception to make sure that any fee you're charging meets that exception when you're talking about requests that are not necessarily being fulfilled for a patient or an app acting on the patient's behalf. And then there are licensing, an ability to charge royalties and to set licensing conditions around the kind of tools that are needed to facilitate interoperability. But obviously you need to meet the requirements of this exception. Next slide, please. Priority area in these rules, as I mentioned earlier, is providing patients with access to their electronic health information and giving patients essentially the ability to do that without special effort. Charging a fee to patients is almost always going to be suspect. So why is it important to sort of think about these information blocking rules in the context of health information exchange and these new rules? And this goes back to something that I mentioned earlier about how, Citizen, which started as really just a patient-facing platform, but then migrated. We actually purchased some software from a company called Stella Technologies that was already providing quality improvement and data quality analysis software to a number of the nation's HIEs. we knew that HIEs faced with these new information blocking rules would be challenged to provide clinical information directly to patients. They're usually not set up to do that. They don't have necessarily relationships with patients. They don't necessarily have a customer service department that is available for patient questions. They don't have patient portals. They don't have mechanisms for ID proofing patients or for getting their consent. And so we recognized that as a company that had both an HIE facing part and also a robust platform with patients already on it, that we actually could play a role in helping HIEs to get into compliance with the information blocking rules and make data available to patients directly. All of the data that they currently are processing or facilitating the exchange of on behalf of their usual customers, healthcare providers, sometimes health plans, depending on what part of the country they're in. Just leveraging those same pipes, that same plumbing to be able to allow a patient to be able to access their data, whether that patient is just coming to the HIE and saying, hey, I know you exist, and I think it would be easier for me to get my data directly from you versus having to go to each one of my providers. Or there's an app or a service like Citizen that is seeking to make a connection to the HIE in order to facilitate the retrieval of information for their patients. Next slide, please. So this, I apologize in advance for the complication, but I'm more of a words person than a diagram person. I know some people who are more visual will take a look at this, maybe not necessarily on your screen here today, but in your spare time, and you can really dive into it and probably completely get what we're doing here. But we have launched what we're calling the Citizen Cures Gateway, which will allow health information exchanges to use their IHE protocols or APIs, if that's the way they're making data available to requesters, to tap into the gateway and enable information to flow down to patients, whether those patients are coming in, we're calling them walk-in patients who don't want to use an app or who haven't chosen an app but are still looking to get their health information, or they're using the Citizen app, or they're using another third-party app that is facilitating the ability for patients to get and organize and manage and control their health information. So this sort of one sort of single plugin that then enables apps and patients to be able to get data. We perform the identity proofing at NIST level 2 of authentication. We get consent, certainly for our users, and we will do that for the walk-in patients in order for them to be able to get their data, but they don't have to keep a Citizen account open. They can take that data and load it up onto their PC or print it out or whatever works for them. And then we will also require apps that connect to the gateway to either use our services for identity proofing or to have NIST level 2 ID proofing implemented, and then to also have the consent of their patients. So I want to wrap up to thank you all again for the opportunity to talk about this. We obviously think that leveraging patient data is a good thing. We think that there are a number of entities that can play a strong role in empowering patients with their data. And we look forward to Paolo's presentation and for the conversation. Thank you.
Devin, thanks so much for your insightful presentation. I know that we're going to hold off on questions until the end for both yours and Paolo's presentation. So for everyone that's listening, please feel free to begin adding those questions into the chat so we can make sure that we prioritize those after Paolo's done with his presentation. But with that, I'm now happy to introduce our next speaker, who is going to be Dr. Paolo Pino. So Dr. Pino is currently the Vice President and Medical Director of Innovation for Diameter Health, which is a Connecticut-based company that normalizes, cleanses, deduplicates, and enriches clinical data from across the care continuum to create a unified source of longitudinal structured patient information for improved care and actionable analytics across different verticals. He provides clinical expertise and thought leadership on existing and emerging regulations, quality measures, healthcare data standards, and technologies relevant to diameter health solutions. Prior to this role, he worked in Optimum Life Reinsurance, where he served as Chief Medical Director, and there he was responsible for medical strategy as it pertains to trends and breakthroughs in care delivery, legislation and governance, changing demographics, and mortality patterns. He's also served as Vice President and Lead Medical Director for Prudential International Insurance, focusing on global innovation for Prudential's markets in Asia Pacific and Latin America. One thing that's going to make Dr. Pino's perspective particularly interesting on this topic is that he has practiced medicine for close to 20 years. He's dual board certified in internal medicine and pediatrics and board eligible in insurance medicine. And in addition to that, he continues today as a clinical assistant professor in the Department of Internal Medicine at Rutgers, New Jersey Medical School. So with his expertise, I know that we're going to benefit from another great perspective. So Dr. Pino, I'm going to turn it over to you now.
Thank you very much, Shreya. Appreciate it, and thanks for having me. So, as part of this conversation, clearly understanding that there's sort of three levels of interoperability. The technical interoperability, that exists, and I think is basically the lowest level. Semantic interoperability, which is what my company really focuses on, and then clinical interoperability. And I wanted to kind of take this opportunity to show you how they all go hand in hand. And so we'll start off with a quote by Don Rucker, who was the National Coordinator for Health IT previously. Delivering interoperability actually gives patients the ability to manage their healthcare in the same way they manage their finances, travel, and every other component of their lives, and essentially to shop for and coordinate their own care with their smartphones. And so definitely a very noble goal, just in terms of understanding the clinical data challenges that exist. So we know that data is semantically non-normalized. About 50% of data exists in non-standard or incomplete or unusable formats. 70% of labs, for example, don't include appropriate vocabulary or units, and up to 40% of medications don't have appropriate coding. Data is definitely increasing, and it's of large volume now. There's about 1 billion care encounters per year across the United States and across the care continuum. About 4,000 different data elements that exist per care episode, about 4 million clinicians, and about 100 plus certified electronic health records. And essentially that leads to fragmentation and siloing of data across each care episode and across electronic health record data. And so in order for patients to really use the data, they have to themselves organize it, consolidate it, and interpret it. And at times this happens without them having the clinical acumen to be able to do that, or they require their providers to essentially do that. And the current workflow for both the patient and the physician is still very patient-driven. So for those of you that have been to care experience recently, you tell your stories, right? It's not like they tap into your previous existing records. Data is sometimes incomplete, and so even when it is at the fingertips of a patient, patients don't know what's necessary in that data, and so they tend to supplement pieces of data that are missing, and again, without the knowledge of what's important. And the challenges of these complexities and organization of data, as well as the data quality, often leads providers to sometimes dismiss or even not tap into some of the very rich clinical data that's important for meaningful diagnosis and treatment. And so I wanted to begin with a patient example. So essentially, this is all history that's obtained from the patient, and just to provide insight that the patient did have access to their medical records. And this is a 70-year-old male and nuclear engineer, just a very well-trained individual, very literate in general, who went to the emergency room in November of 2018 with a chief complaint of progressive shortness of breath, cough, and fever. And previously, there was a history of having been seen in an urgent care center in mid-October of 2018, for which they received a diagnosis of sinus infection because they had severe head and chest congestion, and they were treated with azithromycin, which is an antibiotic, and benzonatate, which is a cough medication. About 2 weeks later, they went to the emergency department with worsening shortness of breath, and at that point, they had a diagnosis that was made of pneumonia in both lungs that the patient reports was actually determined by a chest x-ray. and they were treated with a course of levofloxacin, which is an antibiotic, and methylprednisolone, which is a steroid dose pack. And this is what the patient essentially brought to their care experience. They brought essentially a 4-page summary of their clinical history that they typed up themselves, listing out the pulmonary issues and the 2 visits that I mentioned. And basically, because of the fact that they were at the ER for a lung complaint, they saw this as being pertinent to their medical history. And then they brought in primary care information, which you could see in the yellow box, which the patient saw as being non-pertinent to their medical history. In addition, by the way, they showed up with these records actually printed out from their patient portals. So all of the data was essentially there. And you see that the primary care visit mentions that there's a history of neurologic developments that have been present since October of 2018, so for the last month, where they had progressive pain and numbness in both their arms and their legs, and they also had a foot drop on their right foot. And from a gastrointestinal standpoint, they reported progressive gastroesophageal reflux disease and dysmotility, or the inability of the esophagus to move food down. And again, all of this data in the primary care box was seen as non-pertinent by the patient. Going back to that 4-page clinical document that the patient put together, they also had corroborated with their health history that there was a past medical history of coronary artery disease, hypertension, and high cholesterol. And there were some medications that were included, which were all correct, which are essentially all the medications that the patient was on. But there was key data that was missing from the electronic health records. It was also missing from the 4-pager, but it was verbally supplied by the patient. And that's that the father had a history of arthritis and high blood pressure and died at age 92, and the mother had a history of pneumonia and died at age 89. And you can see some of the data that was derived from encounters that they brought in to the emergency room. So the top data element is actually the discharge instructions from the urgent care center where they were diagnosed as sinusitis. And then the bottom is actually a CT angiogram. Now remember, the patient reported that they had had an X-ray. This was actually done for pulmonary embolus rule out, and there was no pulmonary embolus, but there was a diagnosis based on this of bilateral lower lobe infiltrates presumed to reflect pneumonia, and recommended a follow-up. And so this justifies why the patient was treated by that emergency room visit as being a pneumonia. And so when the patient essentially showed up in the emergency room this third time, they actually had a chest CT with contrast. And it was compared back to a previous CT angiogram that was done about a month ago. And at that point, again, a diagnosis of pneumonia with worsening involvement of 2 areas of the lung that hadn't been involved before was actually made. So the case is closed, right? The patient had right to access. They had all their information. A diagnosis was made based on what the patient essentially told as the story, coupled with whatever gaps could be filled by what existed in the medical records that were presented. And he was treated with antibiotics for the 3rd time for essentially a diagnosis of pneumonia. And so a couple things about pneumonia from a clinical standpoint. If patients don't improve within 72 hours of pneumonia, you start thinking about things like resistant organisms or other complications, and as quoted in the literature, things like malignancy, inflammatory conditions, or congestive heart failure. And so if this patient had a resistant organism, he would have been dead by this point. CT scan showed no evidence of complications. So the reality of it is that it needed to be something else. And so in terms of, the story, there's more. So enter in the nephew, who's a 47-year-old male, knew a thing or two about medical care, and was recruited by his mother or the patient's sister to get involved. And here's essentially a very smart, patient with access to the data, and the data's arrangement was so fragmented that the patient story became the overarching story and actually missed out some key pieces of details. So the nephew actually spoke to the pulmonologist who was admitting the patient after they were started on a course of antibiotics, that the family history missing from the EHR as well as the 4-page document was actually a family history of idiopathic pulmonary fibrosis in the mother, and the father had rheumatoid arthritis with pulmonary complications as the initial complications. It was observed in the records by the nephew that the antibiotics seemed not to work, but when steroids were actually provided, the steroids actually led to improvement that then regressed after the patient was tapered off the steroids. And again, key diagnoses of gastrointestinal and neurologic conditions were actually bubbled up. And so why didn't the providers use all of this rich data? If you were to ask ER providers if 7 electronic health records were presented to them at the point of a need for a clinical decision, how many of those they would look at, the average emergency room physician is going to basically say 0. What's necessary is really a one longitudinal health summary that would essentially lend itself better to decision making. And so essentially what you have for this particular patient is you have patient-provided data, you have primary care, gastrointestinal, urgent care, and ER data that's essentially abstracted according to what the patient felt was important, and a working diagnosis of pneumonia for the 3rd time was going to be treated with antibiotics was essentially made for this individual. And so when the nephew took this data, the nephew essentially took all the data that was left over, supplemented with a little bit of their own metadata based on their knowledge of the family history. And essentially what ended up happening is that all of the data gaps were filled, and the patient was actually diagnosed with a non-specific inflammatory pneumonitis, which was actually diagnosed later as being a complication of Sjogren's syndrome, which is an autoimmune condition that has gastrointestinal, musculoskeletal, neurologic, all of those signs and symptoms are associated. All of that was actually present to some degree in the records, and direction in that was made, but it wasn't capitalized because of the way the data was arranged. So in terms of the role of the nephew, so we know that everybody essentially needs to show up with a nephew who's medically trained to every one of their care episodes. And the reality of it is that medical expertise actually does impact health. Individuals with medical providers as relatives tend to live longer. Families with health professionals are less likely to suffer from chronic conditions. They're 10% less likely to die before the age of 80. They're actually these numbers actually compare better to other professionals that are non-medical. There's a reduction in mortality about 10 to 25 years, 10 to 25%. After a relative graduates from high school. Access to medical expertise will close health equity gaps about 18% of the time. And we're not talking about it being a knowledge issue, but really ensuring that we have proactive, preventive, and well-navigated care is essentially what happened here. It wasn't like the nephew made the diagnosis. The nephew essentially took all the information together to lend itself to make a diagnosis. And so we need to arm patients with data presented in a meaningful way that they can supplement with their voiceover, not allow data to supplement their voiceover. Instead, and this needs to be organized and harmonized to allow patients to have all of their data at their disposal for clinical decision making. And so this is really defragmented care. And so the company I work for, Diameter Health, actually takes all clinical data inputs across the care elements, allergies, encounters, et cetera. We run it through a process called Fusion, which essentially normalizes it to national and international normalization codes like ICD-10 and SNOMED and RxNorm. We enrich it with metadata, so we keep data provenance, but we essentially add in data that's important to the care decision. We reorganize the data so that it's an appropriate clinical domain. So for example, an allergy is in an allergy, a medication is in a medication. We oftentimes will see things like immunizations actually in a medication section. That gets reorganized to an immunization section. We deduplicate it so that a person doesn't have 18 instances of hypertension as a diagnosis. They have one instance of hypertension across 18 separate visits. And then we create a longitudinal summary. And this is a company that was founded in 2013, really under the premise of semantically normalizing data, scaling in the face of growing data assets, and de-siloing patient care experience. And this ultimately, again, helps provide accurate longitudinal health history that leads to contextual care for patients. It identifies data gaps, and upstream it can actually lead to data optimization, and really empowering contextual patient access, marrying new technology solutions in the future to improve some of the data completeness. And Fusion is actually the foundation of the semantic normalization, which is really the precursor to this contextual interoperability. And the 5-step process is really what MyHIN uses to generate the super CCD. In addition, we actually are complementing this with a FHIR Converter that allows HIEs and payers to play and to essentially comply with regulatory requirements of the final rule in the 2021 mandate to ascertain right of access and make sure that the right of access provides quality data. So here's the wild west of coding. So I give you the example of hemoglobin A1C. So you could see to a patient, if it's entered in multiple different ways, they don't really understand the difference between an estimated average glucose and a hemoglobin A1C. So again, there's tons of data that's essentially presented in a whole host of different ways. What Diameter Health does is takes all of this data and essentially normalizes it to one LOIN code, which is 4548-4, which is the LOIN code for hemoglobin A1C. And that happens in subseconds, allowing for rapid clinical interpretation in the hands of the patient. And we're not only limited to issues that pertain to labs like hemoglobin A1C, it really is across all clinical domains. Allergies, for example, aren't coded appropriate. 30% of them don't have any code at all. Lab results, 70% of the times they're not using the right vocabulary or units, and 45% of the times they have no LOIN code associated with them. And nearly 40% of medications don't have the right coding. So that's what we do in terms of normalization. In terms of the scale, so you could see in the left source example, you could see units added to blood pressure and also a LOIN code added to that. And the issue is that there's tons of clinical data out there. So across 300 million patients in the country, there's 3 documents per patient per year that the average individual, will generate as part of their health experience. And just taking SNOMED CT examples, there's about 400,000 healthcare concepts that are understood through SNOMED, 900,000 plus discrete descriptions, and over 1.4 million semantic relationships with these data. And between 2016 and 2020, there's actually an increase in the volume of data by about 900%. We know this because we've dealt with about 100 million patients of the 300 million that exist nationally. And again, all of this happens in sub-seconds. So the goal is to really provide high quality, longitudinal data that's able to show associations and relationships that are interpretable and actionable, ultimately in an accelerated time frame for accurate patient insights at the point of care. And so this is what we need to arm our patients with in terms of making sure that the right of access is a contextual right of access. This is an example of our FHIR Converter, and you can see in the box on the lower left, inbound, you get absence of a code, you get a display name that's sort of a very basic display name, a value, sometimes units are blank, you can't really query. The uplift that we do through Fusion coupled with FHIR is actually in the box on the right, where we actually ascribe a code to it, change the display name, increase, add units to it, and really make easily queryable data for patients. And then this is really the example of what a patient-facing, access could look like. This is vital signs, and this is what's necessary for access that patients need. So it's really this built-in CCD converter that taps into legacy data regardless of form or format. We have a host of different APIs that are both US Core and Karen FHIR compliant, and our number is growing. And again, creating this longitudinal access to patient care is really critical, and again, very important that it's contextual. So just as we start to summarize this, so patient care is fragmented, and again, you can get different care in different care episodes that use different electronic health records, but even within electronic health record platforms, you can get varied data exchange. And essentially, disparate, dirty, and non-normalized clinical data really create gaps in care. And so this is a care journey of a patient who has those gaps. It tends to be very reactive, tends to be a very illness-based model of care. And so what we're seeking to do is actually take all of this data and actually do exactly what was done in MB's example early on. Unify that data so that it's ready for improved clinical outcomes and experiences. This is what powers MyHIN's Interop Station. It allows MyHIN to put that super CCD into patient's hand that defragments, disrupts silos, changes the patient experience, and in the future, it's going to drive patient APIs, provider APIs, payer-to-payer APIs, and again, it'll allow patients to use their data for care, awareness, research, community health, exchange health, and ultimately national health. And this is what the experience of a very proactive care experience looks like. That's essentially defragmented and de-siloed. And so I close off by saying that the patient that I mentioned earlier was actually my uncle. And I don't think that, anything that happened there was, an incredible clinical acumen. It was really just organizing data, bringing it all together. Had he benefited from the cleaning up process that Diameter Health does, probably wouldn't have even need me. Access alone really is only putting patients in the car. It's really important to put patients in the driver's seat and really give them quality data that ultimately leads to their quality care. So with that, I'll end, and thanks for having me.
Dr. Pino, for that presentation that so clearly illustrated the journey that many go on in order to adequately coordinate their care. I can't help but see some similarities between your story and the story of the founder of Citizen, which is even when there is a very educated patient or family member that's really willing to coordinate the care, there's still all those barriers that are in place. So I really appreciate you illustrating that for us. I'm now going to invite both speakers to the stage to answer any audience questions that we may have received and a few that I've documented as well. I do see one here in the chat that came from the audience, so perhaps we can start with that one. So this came from Dan B, and he asked, is there a list of patient data elements that EHR vendors must provide in their interoperable data files? The HL7 standards state required and optional data elements, but we have EHR vendors that will only give you the data elements that you specifically mention you're looking for. Everything else is suppressed. How can we deal with these vendors? And this also might be a question that relates back to some of the information blocking that we've talked about as well. So maybe Devin, we can start with you, and then Dr. Pino, you can add anything that we might have missed.
Yeah, this is, so it kind of depends on Dan, what your position, where you're coming from in terms of asking this question. So yes, there are a list of data elements that electronic health record vendors are required to make exposable through APIs. Those are part of the certification standards. And some of the more, the sort of most complete list in terms of what needs to be exposed through FHIR version 4 APIs, so the updated APIs, doesn't actually have to go into effect for vendors across their entire population of users until December of 2022, but a number of them are already getting upgraded to the sort of more, to the new standard. From an information blocking context, though, which is two separate sort of standards, you know, the amount of data that you need to make available is what someone has requested. So to some degree, there's a little bit of an interplay between, you know, what's sort of technically capable and those capabilities are advancing, but also what a you know, someone who is subject to those rules or who has been asked to provide data is then required to provide is often sort of, it can actually be tied to, well, what did you actually request? So there is a little bit of an interplay there. I will say that for information blocking, it's the US Core Data Set for Interoperability version 1, which is US CDI, at least for the next year and a half. Watching Paulo nod his head. I don't remember exactly when it switches to a more expansive electronic health information data set, but it really does. Yes, there are standards, but depending on, you know, if you were an entity that was trying to get your vendor to make sure that you had data elements included, that would be certification standards. If you're talking about leveraging the interoperability rule to actually acquire data, there you do have to request what you need, and there is some interplay there, I think. I don't know if I left anything out, Paulo.
No, I think you summed it up. And I think some of the challenges that exist are, you know, a lot of the data elements that the US CDI is looking to capture, you know, are not binary, right? And I think that, you know, they tend to vary in terms of how, you know, physicians incorporate those data elements into their workflow, what areas of a clinical chart they make their way into, you know, and so I could tell you that being on a couple of HL7 standards, you know, discussion groups and working groups, you know, it's a real challenge. I mean, look at things that are coming out, things like social determinants of health, you know, how you start to capture that data, you know, where in a chart it gets included. So yeah, there are, you know, the US CDI has published those requirements, which, you know, are going to go in effect, you know, soon. But again, making sure that, electronic health records are compliant, making sure that electronic health records make all that data available in a way that's utilizable, making sure that providers enter in that data, is I think a bit of a challenge. And I can tell you, having documented, I don't always document in the areas of the chart, that seem like an area would belong to, according to USCDI or according to some of these HL7 working group. A lot of it is very workflow driven. So even though you have those data elements, the question is are those data elements going to be populated? And how do we as an industry, and how do we, in the health information exchange space, or, in patient advocate space, start to influence upstream behavior of providers to make sure that not only are the elements, available to be captured, but they're captured in a way that's utilizable downstream.
Great. And then kind of going off of this dialogue that we've started, one question that I have for the both of you is a little bit more broad than that. And that is, do you think that the recent interoperability rules and initiatives have been successful or unsuccessful at helping to unify and normalize clinical data? And then even one step beyond that, are they successful at perhaps addressing previously siloed information through initiatives such as information blocking, pending TEFCA and things like that? What are your perspectives on a lot of these new regulations that we've seen come out over the last 2 years?
Yeah, I mean, so in terms of the success of this, I mean, I can honestly tell you that, interoperability for me at one point. So I actually, when I first started my practice, I went through 3 separate electronic health record platforms. And, I have to tell you, populating data from one to the next was a nightmare. I also, provided care in settings that, a lot of the information was actually entered into a hospital-based system, for example, or even in progress notes that were handwritten. And so interoperability for me in my time frame, which isn't that long of a clinical experience for me, 10 years ago, 15 years ago, information exchange consisted of me hoping that I would photocopy a document, bring it back to my office, hoping that my staff would essentially put it into the right chart. So have we made progress? I think we have. I think that, there's a lot of electronic health record vendors are at the table to have these discussions to make sure that there's transparency and, interactivity of data. Is it perfect? No. I think that's why organizations like Diameter Health and like Citizen exist, because of the fact that, it really is the Wild West, and and healthcare data is not easy to understand, right? It's not a yes or no in most cases. There's shades of gray. A lot of it is very, is very, expansive. It's got, and by the way, just even the way we capture healthcare data, tends to be problematic, because you're asking a provider to have a monologue in their head about all the potential differential diagnoses on a patient, and then essentially confining that through a progress note and further confining that through standards. So is it perfect, and are we capturing all of the data? No, I think we're definitely doing the right thing. I think that there's right players in the ecosystem to help do this. And I think that as technology advances, as the ubiquity of data starts to grow, I think different AI algorithms, machine learning algorithms, get added into this to really, I think, supercharge the way we exchange data, so that it's, even quicker and more appropriate and more expansive than it is now.
Yeah, I don't have much to add other than to say that I completely agree that the picture is much brighter than it used to be. I think it still sometimes feels like we have a long way to go, though. Particularly, there still are a lot of obstacles for patients to be able to get their data, even though that situation is improving. And I couldn't help but look at Paolo's presentation and get, sort of really excited about the work that they've done to make data more usable by patients. And then the work that we're doing to sort of make sure that patients can actually get all of that data. There's a lot of synergies there, but there still are folks who are kind of very reluctant to really kind of turn the spigot on in terms of sharing data with patients more robustly. And that's work we need to do.
Great. And I know that we're running a little bit over on time, but I had one more question. Devin, it's a little more geared towards your presentation, but Paolo, please feel free to jump in as well. In the past, and kind of as is the case in Michigan, most individuals here go to their providers in order to kind of request their information. And then those providers can either reach out to MyHIN to see if we can assist with either exchange or providing any information in line with a right of access request. My first question is, do you believe that with the passage of the information blocking rule, HIEs and HINs will begin to take on a different role when these requests come directly to us from the patient as opposed to through a provider? And before I hand it over to you, I know that you mentioned this a little bit towards the end of your presentation that, you know, HIEs weren't necessarily the best suited to provide clinical information to patients because we weren't really set up to do so. We didn't have the customer service, the patient portals, and so on and so forth. So is this something that you think needs to change, or is it more HIEs and HINs collaborating with other organizations in order to meet these types of requests?
So I think it is always easier for a patient, particularly a patient that's seen multiple providers, to essentially go to one place and get a decent complement of data. Maybe if it's not everything, but everything that their provider can get from other providers in the region or even nationally. And so that's one of the reasons why we decided to stand up the gateways, so that there would be an ability for HIEs to not have to build their own patient-facing solution, but essentially to just plug into the gateway as a node on their networks and then be able to facilitate the sharing of data with patients. You know, I think it would also be possible for a healthcare provider to also query their local HIE and obtain that data on the patient's behalf. That's, you know, however it's possible for the patient to get that data seamlessly is we would pursue all avenues. It's just, we might be faced with a situation, right, where some providers would be willing to take the step to pull from their HIEs and others would not. Whereas, you know, when you have an HIE that sort of recognizes that this is a relationship building opportunity for them to be able to serve the patients in their communities and their needs for data, and then to have a solution that allows them to do that without having to build their own. That was essentially why we're doing what we're doing.
Got it. Great answer. And then Dr. Pini, I'll give you the last word. Anything to add on when it comes to this question or the changing role of the HIE or HIN in the landscape?
Yeah, I mean, I agree with everything that Devin said. The one thing, and I'll just maybe be a little bit more provocative about, you know, blocking and sort of, I think, the role of how different organizations interact with one another. And that's, you know, as a pediatrician who's provided adolescent care, and how you know, kind of navigate, you know, the adolescent care, you know, and what you share with a patient and what you share with their parents, or what do you do with the 26-year-old that's still on the parents' insurance, and what do you do with, you know, medically non-literate elderly, you know, people that have English as a second language, for example, you know, proxies that are not, you know, formalized, you know, healthcare proxies. I also think back to cases where I've seen where I think a collaboration between various entities is important. There's times where stuff that I, as a provider, entered into the patient's chart was critical to keep that patient safe. And so, you know, I would want to make sure that any relationship, you know, with an HIE that a patient may embark on is something that's, you know, really vetted appropriately through other ecosystem, you know, players. Last thing I want to do, and I think back of a kid who I had suspected abuse and neglect with, had actually gone through social work, and social work kind of dismissed it, but I had documentation in the chart. Not that I want to make this grandiose, but essentially having me as a point of contact for his care may actually have been something that probably saved him in terms of untoward medical outcomes. And just having, you know, the data shared in a way that wasn't collaborative, you know, amongst all the potential players that could share data, could have been, you know, detrimental and problematic. And so I think that, you know, speaks to HIEs and HINs partnering very closely with, you know, care delivery settings and with providers, you know, to make sure that everyone's kind of on the same page. And so it's really, I think, greater collaboration that I would advocate for, you know, between all the players of the healthcare ecosystem.
Perfect. Well, I thank you both so much for your time and for your presentations today. Paolo, I know that we have one more follow-up question for you that I can follow up with you on in the chat so we can get that back to Dan. But thanks so much for your presentations, and we will follow up with any other questions that we get from the audience. I think I can turn it back over to Joanne, or I'm not sure if Mary's leading the next one.
Hi, thank you so much. You know, I'm like struck. I'm struck by just this interplay between what's technically capable, right? When I came to work for a health information technology firm, everybody was like, "Well, you know, that doesn't seem like you. You know, you're so human. You're so into people." And I was like, "No, it's just that we're so gloriously human." You know, it's not about what's technically capable. It's really about the dynamics and the relationships and the ethics and anyway, and the shades of gray. So thank you guys. Thank you so much.